Hei, hvor er ditt? Og welcome back to the Midnight Sun Conference, Day 2. We will proceed much as yesterday with some sessions in English, some in Norwegian. Some participants and presenters present here in Tromsø and some present digitally. So we sent out a link for the streaming today this morning again. So if you followed the presentations, you can do that from that link. We still have the same virtual room for digital coffee breaks, link available on the conference website. And we will have hosts for the coffee breaks that will be announced. Both the digital and physical participants ask questions in Slido. Remember to do that during each presentation, and I will direct the questions afterward to the presenter. So even though there were no new positive COVID tests yesterday in Tromsø, we still have to keep 1 meter distance and wash your hands, and the same applies today as yesterday. Also, the emergency exits are located behind the curtains. They will appear if the fire alarm sounds. So we will start out with a session in English on AI and medical imaging. First speaker out is Habib Saidi. He is head of the PET Instrumentation and Neuroimaging Laboratory of Geneva University Hospital, and he's actively involved in developing imaging solutions for interdisciplinary biomedical research and clinical diagnosis. So he has a pre-recorded video, but you can still ask questions in Slido. Just remember to write to Habib, and he will appear shortly after his presentation and answer the questions personally in Slido. So one-time opportunity. Thank you.
Very good. So good morning, ladies and gentlemen. So I'll start with thanking the organizers for giving me the opportunity to address you today. And I think I've been given a very broad stage talking to you about the role of artificial intelligence and deep learning in multimodality medical imaging, and this is sufficiently broad mandate. I probably could have talked for the whole morning session today, but this is going to be one of these talks where we sort of have sections or probably go listen into much detail. Other sections we sort of skip over. Just help to have some time for questions if anything is particularly missing from anybody's expectations. Well, so as a preamble, I would like actually to start by setting the scene and say that AI is not a set of fancy technical developments limited to academia. It will definitely have an important, significant impact on our professions. I'm a medical physicist myself, and probably it's going to be the same on nuclear medicine physicians and radiologists, and probably other disciplines as well. So there are serious initiatives at the European and international level supporting the addition of AI component to existing medical physics curriculum and graduate programs. And the AI work group of the European Federation of Organizations for Medical Physics published recently in Physica Medica, so probably consists of a set of guideline curriculum related to AI for the education and training of European medical physicists. And there are also similar debates taking place around the globe, as illustrated in this interesting point-counterpoint article published in April issue of Medical Physics, which is the official journal of the American Association of Medical Physicists in the United States. So this is not really an outline, but kind of list of topics I'm going to cover in this talk. So start with a couple of slides, or probably 3 slides, to highlight advances in hybrid medical imaging technologies. that we use in our research, and then share with you our experience in the development of AI-based solutions to address specific problems on these imaging modalities. Some of these developments go beyond the scope of this conference. So basically focus on low-dose CT, PET, SPECT imaging, medical image segmentation, so address only CT components, although we have worked also in PETs as well. Cross-modality image conversion is very hot topic, quantitative imaging as well. And then I'll finish this presentation by a few slides covering AI-based internal radiation dosimetry calculations. And obviously, so what you see basically here in purple is not going to be covered here just for the sake of time. Just to start with, so this is the principle of a combined or hybrid PET-CT for those of you who never get exposed to this imaging modality. So basically, we'll start with what we call a scout scan. So scanning basically the patient with a planar image, and you've got the X-ray detectors here in the back, and in the bottom part of the scanner, and the X-ray tube on the top here. So we start with the scout scan. So and then we define the axial field of view, and then we start the spiral CT. And then once the spiral CT is finished, so push the patient towards the PET detectors located in the second part of or in the rear of the PET-CT scan, and then we acquire basically the PET scan, and then we fuse the two imaging modalities together to get the PET-CT scan that we present to our MDs or radiologists for reporting. And basically, so this report is going to be the outcome of this examination. Apologies here. So PET-MR is the second part of the story. So we've got different design trends actually commercialized. So the first one was commercialized by Philips, and this is the system that we have installed in our facility about 11 years ago. And so it's ALA PET-CT, so kind of combined system with the sequential acquisition of the two scans. So we start with the MRI scan on 3 Tesla Chiva MRI scanner, and then you rotate the gantry to push the patient towards the PET detectors, and then acquire the PET scan, and then you basically fuse the two imaging modalities together to get the PET-MR scan. So different design trends have emerged, including the design by Siemens called the MMR. So this is an APD-based or solid-state detector, which is MR compatible, so allowing simultaneous instead of sequential acquisition. Got also the Signa PET-MR system that you see in the bottom here, and then more recently, there is another design by a Chinese company called United Imaging. So these systems actually are designed based on silicon PMs, another solid-state technology, which is also MR compatible. And using those technologies enabled to generate very high resolution images. So these are representative images generated by hybrid PET-MRI scanner, showing the typical quality soft tissue contrast that we get from the MR for brain scans, and so the high definition of myocardium on gated PET-MRI scan. So let's start actually talking about the applications of AI in medical imaging with this article here published recently in European Radiology, where we basically developed a strategy for ultra-low dose CT scans. So basically aimed to design an ultra-low dose CT examination protocol for COVID-19 patients using a deep learning approach, so suitable for significant radiation dose reduction for COVID-19 patients. So according to the physics of CT transmission data, we basically simulated ultra-low dose CT projection data from full dose projections in the cyanogram domain, so just to avoid scanning the patients twice. And this was carried out by adding statistically independent Gaussian noise distribution and the Gaussian noise distribution corresponding to the characteristics that we see in this table. So basically reduction of the pitch factor, the tube current, and the KVP, so to end up with the low dose CT scan. So we use the residual neural network to generate the full dose CD from the low dose CT images, and then without any delay. So show you some of the results from this study. So the quality of predicted cell images was assessed using quantitative and qualitative metrics. So scores assigned by radiologists ranging from 1 to 5. So 1 is obviously the best. No, 1 is the lowest score, and 5 is the highest. So these were assigned reflecting subjective assessment of image quality and also related COVID-19 features. So what you see on the left panel is the representative full dose image and corresponding ultra low dose, and the predicted full dose images on the right side. And obviously the predictions improved substantially the image quality, as you can see here. I don't want to play too much, but I think this is apparent from the scan here, which enables basically most of the COVID lesions to be easily classified by the radiologist. And another example where you see basically on the right side here shows an example of an outlier, which we basically encounter in AI-based developments where the image quality was substantially improved. However, some of the relevant anatomical details were missing, and hence the network failed to recover the full detail of the images, since the glass opacity, so one of the COVID lesions, was converted to another class, which is called consolidation. So we basically lose it, so the diagnostic quality of the scan. On the second phase, we did qualitative assessment, as I mentioned, so by the experienced radiologists, and this is the outcome, comparing basically on the left side, you see the image quality metrics. So where the full predicted full dose images are mostly scored good or excellent, so 4 to 5. And overall scoring shows that the full dose images received the highest score, so 472 as an average, whereas the ultra low dose images were rated basically with the lowest score, so on average it was around 2.8. So on the right side here, you see the frequency for occurrence of each lesion type and the different series of images. So as you can see, so the GGO, so one of the types of COVID-19 lesions, had the highest occurrence in all images, where mixed basically all had the same occurrence for all images, and changes in the essence of features are basically as can be seen here in the ultra low dose groups of GGO was shifted to normal features, whereas consolidation was turned to GGO. So the second work here, presented by one of my PhD students recently at the European Congress of Radiology, and it won the best research presentation. So the idea here is to develop an automated tool for segmentation of COVID-19 lesions. Obviously, so this can be performed on a routine basis by radiologists, but this is time-consuming, labor-intensive, and the procedure suffers from intra-observer variability. So the idea is to automate the process and to reduce the variability. All right, so this is basically the principle of the technique. So we have as an input is the chest CT scan of the patients, and then you've got convolutional neural network targeting basically the segmentation of the lung of the patients and the COVID-19 lesions separately, so in two-step process. So the pretty large database was included in this case, multicentric data sets coming from with patients being scanned in the United States, China, Russia, Italy, and Iran, and with different pathogens from mild to severe COVID-19 cases. And this is basically the outcome, as you can see. So let me take you through some of the results here. So this is one of the studies here. You probably see on the left side here, the radiologist segmentation compared to the AI predictions on the right side. So this is for the two starters, and I think you can see clearly a very good match between the segmentations performed by the radiologist and the one performed by the convolutional neural network. And you probably see it better here on the 3D illustration. So for comparing again, so the segmentation by the radiologist and the AI based solutions, so very good or excellent. So agreement between the two scans. Another application here I'm going to describe is the development of anthropomorphic computational models. So we have some experience in this area. So basically developed a number of computation models for pregnant patients, including the fetus, thoracoabdominal CT scans that we basically segment to generate computational models that can be used as input for multicolor based radiation dosimetry calculations. And we even developed recently a non-human primate model suitable also for radiation dosimetry studies. So this process actually is very time consuming because it takes weeks, sometimes months, to segment manually the organs. So we decided actually to implement a convolutional neural network to automate the process, and then we applied this to a series of pregnant patients scanned in our emergency radiology department. So this is basically the outcome. Without getting through the details of the convolutional neural network, so we see the original scene images, the manual segmentation performed by the radiologist, and the automated segmentation, basically the outcome of the AI-based solution. And again, I think you see very good agreements. Probably see it better here on the 3D illustrations for two cases. You see the features here, which is depicted in this color here. So very good agreement for the two cases, even for other organs apart from the features, which was specifically targeted here because the idea was to estimate the radiation dose to the features from abdominal X-ray CT examinations. So the outcome actually was, as I mentioned, so the radiation dose to the features. And this result here basically summarize the comparison between the models actually resulting from the manual segmentation performed by the radiologist versus the AI-based algorithm. And you see that there is a very good agreement actually between organ doses to the lungs, to the uterus. Some exception probably for the lungs where we got slightly larger standard deviations actually because the mainly of registration issues, and also the uncertainties for this organ was a bit larger. So another application actually is in low dose PET imaging, as you can see from this article here published recently in the Journal of Clinical Medicine. And the idea here is basically to use actually the high dose or the full dose scan, so denoted here as full dose FD, and to use the list mode file actually to generate the destination, the low dose scan, and then train a network with the low dose and high dose and full dose scans to be able to predict the full dose images, so both in image space and in the projection space. So implementing this in projection space was not easy, as you can guess, because it's a time-of-flight scanner, so multidimensional data sets generated by the top time-flight scanner, and this obviously puts a constraint on this set in the sense that we did not include the time-of-flight information for the implementation. So without any delay, again, it just show you here. So the results for one of the clinical studies, as you can see, this is the full dose scan here on the top. So corresponding to an injection of 200 megabecquerel to the patients. So basically 30 minutes wait and time and 20 minutes acquisition time. Very good image quality. And this is the equivalent of the low dose reconstruction, so corresponding to only 5% of the events, with the equivalent of 10 megabecquerel of injection of FDG, or the equivalent of 1 minute of acquisition time. So you see the image quality deteriorated substantially. And then these are the full dose predictions in the image space and in the projection on the synovium space. And overall, the conclusion, as you see from the results later on, is that the deep learning based prediction in the projection space outperformed the prediction in the image space, in the sense that we managed to get rid of some of the artifacts that were observed in the deep learning based implementation prediction image space, and you see this also nicely here in the Bayes maps, actually voxel-wise Bayes maps, where the Bayes were substantially higher actually for the deep learning prediction in the image space compared to the prediction in the sinogram space. So again, we asked a number of nuclear medicine physicians to do the assessment of image quality, and you see that the full dose scans have got an average of 4.47. So yeah, between good and excellent, and then the low dose scan gets the lowest score, so average 1.4. And obviously, as I mentioned, so the predictions in the sinogram space got a higher score, close actually to the full dose scans. So the next step is obviously the quantitative analysis. So we did a number of void-based analysis using the Hammersmith atlas. So basically a line that projects with all the images of the different patients to this atlas, and then we performed so void-based analysis for 83 brain regions. And what you see here is basically the Bland-Altman plots where each data point reflects one brain region. So this confirms the results obtained from the joint histogram analysis, where the lowest SUV values and smallest SUV values were observed for the predictions in the sonograms space. And although the SUV values was extremely low for the low dose images, there's an increase in the variance compared to with the full dose predictions, as basically reported also by our nuclear medicine physicians. So the other studies basically so to achieve quantitative imaging again, so kind of extension of the previous work to use deep learning so for ultra low dose whole body imaging, so extension from brain imaging to whole body imaging. And so this is what we did basically in this study here. So we walk you directly through the results. What you see here is one of our patients. We see a representative F18 FDG whole body PET image of a 66-year-old female patient, where you see the low dose CT image used basically for attenuation correction and anatomical mapping. And then you see the reference full dose images next to it, and the corresponding low dose images, and the predicted full dose images using basically so two different architectures, so residual networks and the cycle generated adversarial networks. So these are two different architectures used widely in medical image analysis, and obviously the low dose scan corresponds basically to 1/7 or 1 to 8 of the equivalent full dose scan. So the cycle GAN actually achieved a very good image quality and outperformed basically the residual network evaluated in this work as well. So this is these are basically the top panel. You see the image quality assessments by nuclear medicine physicians for the low dose, full dose, and the two neural network architectures using this work. So basically residual network and the cycle GAN. So each scores are presented on the top of the bar, and obviously so you understand the principle of qualitative assessments. So 1 goes to an interpretable image quality and 5 is excellent image quality. So on the bottom part here, you see the percentage of failed and accepted images, where failed was assigned whenever so lesion detectability was not good compared to the image displaying best image quality, and the two defined anatomical regions are shown on the right side. So basically we split it so the whole body image into two zones, so one covering the brain and the head and neck, and the second one basically so covering the breast and the abdomen and the pelvis as well. So with regard to lesion detectability, so we asked actually our nuclear medicine physicians to report on lesion detectability. So both CGAN and residual network performed well, so depicting 19 out of and 17, so out of 19 lesions respectively. For lesions with high uptake, so basically SUV larger than 5.5. However, CGAN performed much better compared to the residual network. So depicting 27 and 23 out of 28 lesions for lesions with a reduced SCB or low tracer uptake and smaller size. So these are representative examples of lesion detectability shown in clinical study with the multifocal, multicentric breast cancer with the skin involvement of the right breast and extensive lymph node metastasis, including the mediastinal nodes, comparing full dose and low dose images, as well as the synthesized images using both networks. So the lesion in the inferior external quadrant, so the long red arrow that you see here, was detected on the full dose, low dose, and the cycle GAN, but we said on the residual network. The mediastinal lymph node short red arrow indicated here was visible on the full dose and cycle GAN, but missed on both the low dose and the residual network. So significant achievement actually of this work. So another work that was performed by our group is basically to develop adversarial semantic structural learning strategy containing two generative adversarial cores for city synthesis. So basically what you see in the upper panel and semantic structure extraction, so what you see in the lower panel. So the city synthesis core is governed by an L2 norm loss function for accurate city value estimation, while the semantic structure core exploits cross-entropy loss functions to maximize the fidelity of the generated synthetic CT for the target MR image. And the city synthesis and semantic structure cores are composed of 22 and 16 layers respectively, and in total network contains about 54 million trainable parameters. So without any additional delay, so we'll show you the outcomes. So this is basically what you see here, the MRI and the linearity of the same patients, and the deep learning strategy does a good job in depicting specifically the bony structures and the nasal cavities, whereas the commercial implementations on the Philips scanner is very crude approximation. So basically segmented MRI into single tissue class, which is soft tissue inside the external contours, and you see also on the bias maps substantial loss of quantitative accuracy, as you can see here. So these are again some results for another patient here. We see the MRI reference CT, and we compared actually the deep learning network to an atlas-based segmentation procedure developed again by our group, and we looked at two different quantitative metrics regarding the city value estimation. So both deep learning and atlas-based method performed similarly for the entire head region, resulting in mean absolute error of 101 and 103 Houston units respectively. However, these methods outperformed actually the segmentation based almost in all of the reported metrics. And as I mentioned earlier, so deep learning techniques might result in gross errors due to the vulnerability of the quality of the input data, especially if you have some anatomical variability and also in the presence of high noise content. So in this study, there was a single case of an outlier that was observed for deep learning based strategy. So similar to other techniques basically reported in the literature. So this is another work that I don't have the time to cover, just to show you that what I mentioned that can be done in the image space can be done also in the sinogram space, especially if you have time-of-flight scanners, so you can actually devise similar procedures in the sinogram space, so taking advantage of the high temporal resolution of equivalent time-of-flight PET scanners. So the other work that I'm going to describe here very quickly is joint attenuation and scatter correction in image space directly. And this basically the idea here is for implementation. So we use three different techniques. So 2D slice by slice implementation versus 3D using patches, and then fully 3D on the 32 slices. And the reason for choosing this number of slices is basically the memory limitations of the graphical processing units that was used actually to do this work. So this is directly the outcome of the study. So shows you actually head-to-head comparison of the representative clinical example of PET's image non-corrected for attenuation. So close to the CT scan that you see on the left side, and the PET scan corrected for attenuation using CT-based attenuation correction procedure implemented on the commercial scanner. So this is the de facto standard technique actually used in commercial systems. And these are the predictions actually by the different approaches implemented in this work. So basically 2D slice by slice, 3D gel patches, and then 3D slices consisting basically of 32 slices, and you see the base maps here on the right side. So what was important actually to notice in this study is that one of the issues actually that we face in clinical setting when you use CT-based attenuation correction is the misregistration issue in the thorax and the upper abdomen that takes place in 20 or 30% of the cases. And so the MDs are obliged to look to the non-corrected images actually to solve those issues. And basically, so what's happened here is that we noticed that in some cases, so the deep learning strategy managed to solve this problem in the sense that it compensated for this motion issues. So basically taking place because of differences in breathing patterns between the PETs and the CT scans. So the last example I have here is internal dose image. I hope that I did not exceed my time. And so the idea here is that we know that in current practice, so dose monitoring is commonly performed using simply modified models, such as those devised by the Medical Internal Radiation Dose Committee. And the voxel level mirror schema is defined basically as a 3D voxel-wise matrix implementing the mean absorbed dose to target voxel per unit activity in a source voxel embedded in infinite homogeneous medium. And the idea of our work is basically to extend the voxel scale mirrored approach from a single S-value kernel to specific S-value kernels corresponding to patient-specific anatomy to construct 3D dose maps using hybrid emission transmission image sets. And in this context, we'll basically employ deep convolution neural network to predict the distribution of deposited energy representing specific S values from a single source in the center of 3D kernel composed of human body geometry. And the training sets consists basically of density maps extracted from CT images, and the reference voxel-wise S values were generated using Monte Carlo simulation. So to assess the impact of medium heterogeneity on dosimetry results, so we generated the whole body dose map of the positive energy that was basically compared actually to the Monte Carlo calculations. And I'm going just to skip a couple of slides here, just for the sake of time, and skip again the summary and thank my team for their excellent work. And I thank you also for your attention. Happy to answer questions. And again, thank you very much for your attention. Thank you so much.
Thanks to Habib. As mentioned, he will answer the questions in Slido personally in a few moments. So we will move on to Tomoyoko Irino. He will participate digitally. So again, ask your questions in Slido and I will direct them afterwards. So Tomoyoko is an assistant professor in the Department of Surgery at Keio University in Tokyo, Japan. His current research focuses on artificial intelligence in cancer diagnosis and surgery using medical images and its clinical application. He will give us an introduction to the state-of-the-art artificial intelligence in surgery in Japan.
Good morning, everyone. My name is Tomoyoko Irino from Japan, and thank you for the introduction. And I wish I could be there, but due to the corona, it can happen. So today I'm going to talk about the AI use in surgery in the clinical medicine in Japan. So let me start my slide. Today, I'd like to talk about the AI in surgery and the clinical medicine in Japan. Before my talk, I'm afraid most of you don't know me, so let me briefly introduce myself. I'm from Japan and currently working in Japan, focusing on upper gastrointestinal cancer surgery, esophageal and gastric cancer. I've worked for Karolinska Huddinge in Stockholm for 2 years with Professor Magnus Nilsson, when I got to know Dr. Arik at UNN and Dr. Arik, Professor Rolf Wolle and Professor Atul kindly invited me to Tromsø twice. And please don't take me wrong, I'm just a surgeon, not an AI expert, so AI is just one of my hobbies. Today's topic are these two. First, I'd like to talk about the clinical application of AI in diagnosis, and then I'd like to give you a brief introduction of my research using AI. So first, I'd like to talk about the clinical application of AI in Japan. And firstly, AI in gastroscopy for early stomach cancer. Secondly, colonoscopy for colorectal neoplasms. And thirdly, I'd like to show you AI in ultrasound screening for breast cancer, which has been developed by my colleagues. Well, I'm afraid that most of you are not so familiar with stomach cancer, but it's been a big problem in our country. And therefore, since 1980s, screening program has been performed to find them early. So thanks to the screening program, we can take gastroscopy almost everywhere. I mean, not only physicians in big hospitals, but also even general practitioners, they do gastroscopy in their small offices. As a result, 60% of stomach cancer are early cancers in Japan. But early cancers is basically very, very small, and even experts sometimes find it difficult to detect. So with gastroscopy, the false negative rate is estimated up to 26%. So you see the right up there, there is an early cancer, which you may be easy to find, but how about this? It looks very flat and sometimes you might miss it. So how about this? Even for experts, it looks very, very difficult to find, I guess. So here is the cancer, and now you see how early cancer looks like and how difficult it is to find them early, especially for non-experts. So the first study I'm going to introduce to you is screening gastroscopy using AI. So the first author, Dr. Hirasawa, is my colleague, and he and his team did an awful work on this topic. So they used deep learning algorithm with 13,000 gastroscopy pictures for training and annotated manually. So annotation on over 13,000 images, which sounds really laborious actually. Then they tested the model with over 2,000 newly collected images, and this is the result. T1 means early stomach cancer, and patients with T1 cancer usually do not die from stomach cancer if appropriately treated. So this is very surprising. Cancers over 6 millimeters, and AI could find them with a sensitivity of 98%. So cancers less than 5 millimeters, AI missed them so often, but even for experts, it is very, very difficult to find such a small cancer. And next, they applied the AI model to video clip and got a 94% sensitivity, which was similar to the still images. So a video is worth 1,000 PowerPoint slides, so let's watch a video clip.
Real-time diagnosis using CNN system is displayed on the left screen. When the probability of existence of the lesion reached a predetermined threshold value, the lesions are pointed out with blue rectangular frame. Case 1. The superficial depressed type lesion in the posterior wall of the antrum. The CNN system correctly identified the lesion with white light imaging and also with NBI. Case 2. superficial elevated type lesion in lower body. The CNN system identified the lesion immediately after it appeared on the screen. Case 3. Our CNN system also could identify slightly reddish superficial depressed type lesion on the lesser curvature of the lower body. Case 4. Our CNN system correctly distinguished the lesion from surrounding gastritis.
So this is an amazing work actually. And this is the result of expert versus AI using nearly 3,000 gastroscopic pictures. As you may expect, AI could process 3,000 images 230 times as fast as humans, and AI was superior in sensitivity, but humans were superior in specificity. And currently, this AI software is being submitted to the authority for approval for clinical use. So next, I'd like to show you Endo BRAIN study, and this study was designed to obtain regulatory approval of an AI-based software, Endo BRAIN, by the authority. Endo BRAIN is an AI software which is directly connected to the endoscopy unit and predicts a polyp's pathology, neoplastic or non-neoplastic. So this software works with endocytoscope, which is an endoscope with the function of 520-fold super magnification. So it is now commercially available in Asia, EU, and Middle East countries.
This endocyte is a very unique endoscopy. The images with endocyte are well correspond to histological images in each specimen. So for example, a cancer by endocyte looks like this, and its histological appearance is like this, and you see both are very similar in their appearance. The Endo BRAIN software is designed to differentiate neoplasms from non-neoplasms to avoid unnecessary polypectomies. The algorithm of Endo BRAIN is not deep learning with neural network, which has a black box problem, but support vector machine with 312 dimensions. They are trained with nearly 70,000 endocyte images and tested with 100 images. As a result, the software achieves 98% sensitivity and 97% specificity, which is very impressive. So I'm going to show you how endocytoscope and Endo BRAIN work. So the first case is 5mm adenoma. So now you see a polyp there, and now get closer, then contact and magnify. So as soon as you take a picture, the Endo BRAIN software starts analyzing it and then gives the probability whether this is a neoplastic or non-neoplastic. So this is a stain mode. So this is neoplastic and you need a polypectomy. So this is highly likely non-neoplastic, so you don't have to do a polypectomy for this small polyp. So how about AI versus experts? Actually, AI did really well and clearly defeated experts, but the differences are not so big actually. I mean, it was statistically significant, but clinically not so big difference. So both show a clinically enough ability of diagnosis for those lesions, I think. So now there are several series of Endo BRAIN available in Japan, Endo BRAIN I for polyp detection, Endo BRAIN Plus, which can differentiate cancer from benign polyps, and for ulcerative colitis, Endo BRAIN UC. So all softwares have got approval from the Japan authority and currently commercially available. And the important thing is these softwares no longer learn once they get approval. As you know, one of the strong points of AI is the more AI learns, the smarter it becomes. But this is not always true. So they would give lower accuracy after further learning. So this is the reason. And the prices are like this. And what do you think? Expensive or cheap? It's just up to you.
So the third study is AI-assisted screening ultrasound for breast cancer. This project is led by our breast cancer team of my department. So in breast cancer screening in Japan, mammography alone is recommended, but previously a large randomized control trial was conducted in Japan comparing mammography with a mammography plus ultrasound in breast cancer screening for women in their 40s. And the result was that adding ultrasound actually improved both detection rate and sensitivity. So in near future, ultrasound would be recommended in addition to mammography, at least for 40s. But not all ultrasound practitioners are experts, and it'll take very long time to rate them up to expert level. So our breast cancer team has developed an AI-assisted ultrasound for breast cancer screening called Midnattssolkonferansen. And Midnattssolkonferansen uses deep learning with convolutional neural network and was trained with 630 images and tested 271 images. Annotation was performed manually, like these figures right there. With the test images, Midnattssolkonferansen achieved a sensitivity of 84% and a specificity of 86%, which is also.
So let's see how it works. So as soon as the examiner finds a nodule, a tumor, the software gives a probability how likely the tumor is a cancer. So we are now 91% confident that this is a cancer. So now let AI fight with humans. The AI achieved 100% sensitivity and 91% specificity, while surgeons, including young residents, showed only 67% sensitivity and 81% specificity. This suggests that the software would help with making a correct diagnosis in the breast cancer screening. So currently, this AI software is being submitted to the authority for approval in clinical use.
So far we have a look at the studies AI versus experts and its clinical and commercial applications. But I believe AI may be able to recognize what humans cannot recognize. I mean, images may have much more information than we think, and AI may be able to reveal it. So I'm going to show you my piece of work using AI picture analysis in stomach cancer surgery, where my expertise lies. So the research theme is deep neural network for the prediction of lymph node metastasis in clinical T1 node negative early stomach cancer. So an interesting study showed up in Nature Medicine, in which deep learning could predict genetic disorders by analyzing patients' face, in other words, facial phenotypes. So this is one of the figures of an article. The input is an image of girl's face, and the output is probabilities of genetic disorders the girl might have. This study means that human face is likely to have much more information than we think, which we cannot recognize, but AI can recognize. In other words, we could predict genotypes by analyzing phenotypes using AI. Tumor phenotype may have much more information as well. For example, we describe this tumor as 02C, 30 mm, no ulceration in the tumor. However, there are in fact many 02C tumors like this. And the thing is, they are the same 02C 30 mm ulceration negative tumors, but have different faces, phenotypes. So phenotypes are closely related to genotypes that regulate biological behavior, like metastatic ability. So my hypothesis is that the tumor appearance, in other words, tumor phenotype, may partly represent a certain type of genotypes that regulates biological behavior. In this study, I tried to predict lymph node metastasis in early gastric cancer by analyzing gastroscopic pictures. So to establish a model, I prepared 164 endoscopic images consisting of 82 lymph node positive and 82 lymph node negative tumors. Then split them 9 to 1 and 9 for training and 1 for validation. I prepared another 40 images to test how well the model could predict lymph node metastasis. In this study, I did not use any information on patient characteristics, but they are alike between the groups. So this is the results. Overall accuracy was nearly 67%, which is not amazing, but fair enough, I think. And the accuracy for lymph node positive was 84%, but for lymph node negative, it was only 48%. But the possibility of 26 correct answers, if at random, is only 4%. So I would say the result is significant. So as a comparison, I showed two different predictions. I established another model using logistic regression analysis, which is commonly performed in medical research, but it resulted in only 50% and no tumor or patient characteristics was chosen as a significant predictor. And how about experts? I asked 8 surgeons from expert junior residents to classify the 40 images into lymph node positive or negative, resulting in the graph, the right bottom. So this is very interesting because all surgeons said, I have no idea at all. But the result is the more experienced, the more correct answers. This suggests that experienced surgeons might recognize something related to lymph node metastasis from the pictures, but they are totally unaware of it themselves. And AI may be able to recognize it, I would say. So if we are able to recognize what AI recognizes, we would be able to predict as AI does. But of course, the things are not that simple. This is so-called AI black box problem. It is usually difficult to understand where the output really comes from. So these pictures are extracted features by AI, which I visualize from the network. And at least for me, I can understand the features. So in general, the features AI extract from pictures are almost impossible for us to understand. This is one of the drawbacks that deep learning has. That is, even if AI predicts correctly, we can understand how AI predicts. Big effort has been made on this issue called explainable AI, but it's still on the way. So in that case, experts can learn from the pictures, but there are another problem there. So there are not so many endoscopic pictures there, so it is also very difficult for humans to learn. To collect a large number of medical pictures is always challenging. Well, we are heading for a solution. StyleGAN is an amazing technology that can synthesize artificial pictures, in other words, fake pictures from authentic pictures. And the fake pictures contain features of authentic pictures. By using this technology, we can make a large number of endoscopic pictures that contain specific features of cancer, and we may be able to learn from the fake pictures. So let's have a look. Remember, we have a problem with the shortage of pictures of early stomach cancer positive for lymph node metastasis. These are authentic images, and we can now generate a large number of fakes using StyleGAN. So let's have a look at generating process. First, it looks a mess containing only very primitive features of the authentic pictures, but you see, it is getting clearer and clearer. So unfortunately, this process requires very strong power of computer, but mine is totally not enough to generate clear images. So I use Google Collaboratory. Still, it's not enough actually. So I would like to move further anyway to prove my hypothesis, and I hope it helps with our clinical decision making. So there is actually a black box program of AI, but now AI can draw pictures that are strikingly similar to authentic ones. So using this technique, humans may be able to learn from them. We currently let AI fight with experts, but we need to cooperate with AI. That makes us much stronger than we are.
Thank you so much, everyone. And again, congratulations for this prestigious Midnattssolkonferensen. Thank you.
Thank you very much to Tom.
Thank you very much. Thank you very much. Sorry for disturbing you. Yeah.
Yes, and sorry for the technical problems. So due to that, we don't have time for questions, but there has been quite some questions in Slido. And as Tom was sharing his email address on the last slide, yep, you're welcome to contact him. I'm sure he's eager to answer.
Absolutely.
And also the presentation will be shared.
Yeah, of course.
So thank you very much, Tom.
Thank you very much. Thank you.
And we will now have a coffee break. It lasts until 10:25. We have the virtual room where NSE has a table ready to discuss, and also Fagnettverket for kunstig intelligens i norsk helsetjeneste also has a table where they welcome you for discussion. See you back here at 10:25.